and we would like to welcome you to today's session. What an unprecedented time to be having this discussion, as we all are aware of what has been happening. And to introduce the theme of today's discussion, it's going to be the path to sustainable healthcare in Africa. We have an amazing panel here. We have an epidemiologist, we have practitioners, we have social entrepreneurs, and I will be your moderator. Wilfred Njagi is my name. I'm CEO, co-founder of Wilgrow Kenya, a healthcare business incubator in East Africa. So before I introduce the panelists, let's take a few seconds of silence just to remember and send some love to remember all the human suffering happening now, the lives lost, that we don't run into diminishing it to a mere statistic. I mean, these are real lives like you and I. And for a minute, let's send some love, compassion to the world.
My name is Diana Ruchugo from Bamburi Cement. I'm responsible for health program within the organization as well as in charge of the medical program that we have. So as a private sector company, our core business is in construction. We make building materials that people can be able to access as part of also development. So in the space of health, one of the innovative things that we've been able to do, we've been able to come up with a unique product, actually in terms of partnership with our retailers who largely play in the space of SMEs, small micro enterprises. So we've come up with a medical scheme known as Afya ya Nguvu. So Afya for Health and Nguvu, our flagship product, our premium cement product. So what this particular cover has done, it has been able to give our retailers who are mainly small scale people to be able to access healthcare. Because as we all know, and I'm sure all of us have experiences and stories to tell about the fact that healthcare can be very expensive. And when you need it, you need to be able to access it, and cost shouldn't be a barrier for it. So we innovated this scheme. It's a sort of like an affinity product for the retailer who owns the shop. They can have it together with their family or have the cover dedicated to his workers who are also working in there. And we're really proud of that particular innovation. It's the first of its kind in this market. Thank you.
Thank you very much, Diana. It's good that you brought out one of the barriers to accessing healthcare, which of course is a financial barrier.
Yeah.
And now moving on to my right, I have Maximilian. Introduce yourself and what Hirara is doing, especially which barriers to access of care are you addressing? With financial barrier taken care of, which other barriers is Hirara looking at as introduces?
Many barriers indeed.
Yes.
Morning everybody, I'm Maximilian. I'm the Chief Strategy Officer at Hirara Health. What we do is we work with small primary care clinics located on the outskirts of your large urban centers in Kenya today and then beyond tomorrow. And we leverage development in point-of-care diagnostic technology that are taking those very large, expensive, complicated to use diagnostic tools and turning them into tools that are simpler, much more affordable, and that have some form of tech component that facilitates usage. We partner with these companies around the world, bring their tools into Kenya, integrate them into what we're building on the technology side, and we offer this bundle with financing to these small facilities, where we try to decentralize access to diagnostics, bring it closer to the communities. To answer your first question, what specifically innovative it is that we do, we have a project today in trying to democratize access to ultrasound, which I know Melissa is also working on as well. And we work with Butterfly Network that created a very small, portable iPhone or Android compatible probe that you can place in even your more rural areas. And what we're trying to work with is, can we connect centralized sonographers to provide real-time direct support to clinic officers who are not sonographers, who struggle to access those sonographers, such that they can offer basic imaging to their patients. And we've been quite successful with that so far. In terms of UHC, our main focus, I think, is on something that doesn't tend to be forgotten, but isn't always from place, and it's the actual quality of the care. And we work with a number of academics around the world who try to stress that access to care is by all means very much a problem, but the actual quality of care, once accessed, is even more so a problem. So by bringing access to high-tech diagnostics that are accurate and affordable, we try and bridge that quality gap, improving patient outcomes.
Thank you. Now we have heard about financial access, now democratizing diagnostics and accessing the point of care diagnostics and quality of care. And as Dr. Teresa introduced yourself, I think it would be good to see how does all this come together and what is the role of academia, which you represent here. How does it help us now have that triple helix using evidence-based approaches to either verify whether Maximilian or whatever he's working on is working or not, and whether Diana is actually increasing access or not. So we need evidence-based approaches. Yeah.
Thank you very much. My name is Teresa Kinyari. I'm a clinical epidemiologist and a lecturer at the University of Nairobi. I'm also the chair of the Public Health Society of Kenya. And at the Public Health Society of Kenya, we are multidisciplinary and multi-sectoral membership that involves developing partners, colleagues who work in the developing partners, and ones who work in the private sector and also in academia as myself, and also in the private sector and a non-government organization. So just to go back to what Maximilian was saying, for us in academia, we are looking at proof of concept. We have new evidence coming in, and especially now with COVID, as members of the task force, we have a lot of new information that we are all learning about COVID disease and how to manage it. So from the academia point of view, we are looking at what really works in terms of ensuring that we're able to increase efficiency, being able to provide the quality of care using less and more value for money. So one example I want to give is we have our membership cuts across different technical advisors, some working even with the Africa CDC, the United Nations, and different organizations. But I speak for myself from academia. During the COVID response, most of our members were part of the task force. And we saw that we have a challenge in testing everyone. We've not been able to achieve mass testing. So we thought of doing syndromic management, and the fever monitoring was key. So a few of us came up with a non-contact thermometer device that would be used not just for the individual, but more on a community level. So you're looking at it from a Nyumba Kumi perspective, where it can be placed centrally, just like the way you have it in a supermarket. But then now using network and machine learning, you're able to project that using GPS coding to be able to identify what the fever maps are in different areas. And this would actually be very useful, especially now that we can't afford testing. So looking at it from a national government point of view, this particular device would be important because it would be able to, it would help the government identify the hotspots in terms of fever and other symptoms, and linked to what Marcelo has been doing in the health facilities. The health facilities are actually the point of care points for service delivery. So if these machines could actually be placed at the point of care in the health facilities, then it's easy to pick up new emerging symptoms and help save lives, because then you'd have early diagnosis and treatment of most of the diseases. And the challenge we're having now is community diagnosis of COVID. And we know that we probably have a lot of community deaths that are probably not being diagnosed. And again, even not just looking at COVID, we have seasonal variations in influenza and other diseases. So that it would actually be very useful in doing that. That way then you know, for example, if you have a peak season in July, you can put in more health workers. Our public health society really looks at human resource, so we can actually be able to think, can we be able to contract more health workers during that time and to increase efficiency.
I wake up. There's new evidence, new information around COVID.
Yes.
Once you're told masks don't help, the other time you're told only wear masks when you're in the crowd. The other time you're told wear masks everywhere, and it keeps changing. It's very confusing, right? And we'll be coming to that in a bit, especially the role of in disease surveillance and epidemiology. And then Melissa joining us remotely. Welcome to this panel. Please introduce yourself and tell us how is Access Afya contributing towards this democratization of healthcare information and increasing access to health.
Hi, everyone. My name is Melissa, and I'm the founder of Access Afya. We're a social enterprise that is running physical and digital primary healthcare services in 4 counties in Kenya right now. And our model is 2 different ways to access care. The first is through fully digital primary healthcare clinics that are still physical spaces where patient information, supply chain data, post-consultation engagement tools are all being handled through a suite of software systems. The second way patients access care with us is through MDaktari, which is our virtual clinic, which takes all of the best practice we spent 7 years building up in our physical clinics and puts that online. I'm going to talk about, to get into a specific innovation, I'm going to talk about kind of a disrupted patient journey. And that's really at the core of what we're looking at, is how do patients experience care in a different way as one innovation that we're working on. And let's think about a patient who has a non-communicable disease. We've done a lot of work in diabetes in the last 4 years, for example. So if a patient has diabetes or even hypertension, the first thing we've realized in terms of health information is that they probably don't know that they have diabetes or hypertension. 80% of the thousands of patients that we manage at our clinics for these conditions had no idea they were at risk for them until they went through our risk screening and diagnostic process. Pre-COVID, most of our work with this was in community spaces. That's one thing that's really changed this year. Because if somebody doesn't know they have a condition, you can't do your job at a clinic. You have to do it in the field where people spend their time. How we've started to innovate on this this year is by relying more on SMS-based risk questions and smaller group information sessions to try to get the information out. When we are actually teaching about this, the tools that we use are a very simple custom mobile application that guides a non-physician and also non-clinician level of health worker, like a community member, through a series of questions to ask and measurements to take. And by the end of that simple mobile phone-based screening, you'll have a risk score. We have a tech product called Health CRM that then brings those scores together and actually shows our central team who in our communities is at risk of diabetes or hypertension. They then get a series of SMSs and phone calls to prompt them to come into a physical clinic, where we then do a comprehensive diagnosis, which of course requires more lab work and oftentimes multiple readings to be sure. So the physical clinics are still come in handy. A patient needs to get a blood test done. A patient might actually need more advanced testing, like a kidney function, depending on their condition and the severity. So we'll run all of our diagnostics on site at our clinics and then put the patient on a care plan, which involves a series of over-the-phone digital counseling sessions. Because as we all know, if you have a lifestyle condition, you need to actually change certain elements of your lifestyle. So we talk about nutrition, we talk about movement, we talk about weight, if that's one of the contributors, we talk about smoking. And all of this is done by either clinicians or even health coaches over the phone in between visits. What we've sort of done with COVID is we've really accelerated this to actually do about 90% of even the clinical work over the phone, so that a patient really only needs to come to a clinic to pick their meds. They can even prepay. So their actual risk of sort of exposure coming to a clinic is minimized because they can have their consult over the phone, prepay, come, their medicine is pre-packed, pick it, and go back on their way. And then, of course, these conditions are a journey. So some of the things that we've worked on in terms of after that initial visit is different ways to incorporate best practice from behavioral econ. Because we all know that about 11 months into your journey with a condition like hypertension, you've spent money, you've spent time, you're still on meds, and you're not, you're frustrated. And so that becomes a behavioral problem, not a healthcare problem. So we have teams working on what message do you need in month 11. It's different from the message you need in month 2. What kind of messages do you need in month 15? How do we create a program where by month 36 or 48, you actually can move off of medication and stop spending money on this? We have about 3 years of data on this program right now. So still investing a lot in what the different sort of changes are needed over time, but have achieved really world-class results with the majority of our patients at least moving out of crisis stages of their conditions and at least into a state of control plus meds. So this is one example of how we've thought about a conventional patient journey and tried to really disrupt it using community-based health access points, but also digital tools to make us smarter in the management of that journey.
Is Africa ill-equipped to address its healthcare challenges? We saw a number of predictions by well-renowned people that people here would die in the millions, which has not happened, thankfully to God. And even the severity has been quite moderate compared to what had been predicted. We are nowhere close to the peak that had been predicted. And using that, should we say, are we equipped to address our healthcare challenges in the continent? That's the first part. Do you agree or disagree? And the other question is, due to COVID, have we regressed towards attaining SGD3? Yeah. So are we ill-equipped to address our healthcare challenges? And has COVID-19 in any way helped us regress or progress, because it could be the other way also, towards attaining SGD3? In no order whatsoever.
Okay. Happy to first go ahead. I think, to be brutally honest, yes, we are ill-equipped. If we look at the number of ventilators, the actual PPE, with the actual diagnostic equipment that you find across the continent, it's very hard to hide behind the fact that there's limited developed infrastructure to address this. But then to try and take this into a slightly more positive sense, we also have a certain healthcare system across the continent that you won't find elsewhere. There are about 15,000 primary care and above facilities across Kenya. There are about 1,000 to 2,000 in France. This notion of decentralization and having some form of healthcare presence deep in the community opens up many, many doors for innovative ways of treating care. So yes, there are troubles, but equally there are pathways to improve the care that can be offered. To address your second one, have we regressed in SDG? Even there, yes, because as you said, it used to be a world where patients would seek out doctors, and the efforts that have been put in place over the past decades have been to try and get as many patients to those doctors. But where patients now are fearful of going into these large facilities or not going to have their A and C checkups at your large facilities, that they view that as COVID hotspots, you are regressing in that form of coverage. But then again, trying to take out the positive out of this, this opens up a whole new world of how can we address this in innovative ways in this COVID scenario that will hopefully accelerate the achievement of SDG 3 when it comes.
I think when it first started, with the fear of going to health facilities, I think there has been reports of vaccinations program being heavily impacted, the ANC programs. And when you look at the SDG goals, the renewable goal number 3, we talk about good health and well-being. But when you look at indicator 3.2, which is about infant mortality, we had already made a lot of gains there in terms of SDG achievements. But now I think with COVID, I think now we need to again to relook and reassess that, how much of it has been impacted and what were there opportunities for us to look at it differently now that we have community health workers there. And we maybe need community health workers going out as opposed to waiting for mothers to bring their children to health facilities. So I think there have been quite a number of interesting opportunities with COVID to meet the SDG goals.
Thank you so much. Melissa, do you agree or disagree with these sentiments?
So it feels like one thing that we could agree on is it has exposed some gaps in the system, and there's a thread here around using data. I couldn't quite hear everyone perfectly, so I can't tell if this was said. I think one thing that we were very good at was the public health side. Locking international travel down and having people wear masks, while this was still being hotly debated around the world. So I think there were some very common sense things that were done. And that kind of showed sort of well equipped to think about public messaging and policy. I think that my kind of initial reaction was a bit of the last point, and kind of building on that, there has been some data compiled. I think Gates just put out a report yesterday on how Kenya's vaccination rate dropped from 85% of children covered the last 4 or 5 years in a row to 70 this year. So we are seeing real kind of positive trends being reversed. A really good example of that is, so last year, we saw in the communities we worked constant polio campaigns. Community health workers, free immunization drives, pop-ups, postering, and that's been completely paused. And partially because resources have been reallocated, but also partially because there was concerns around social distancing and how you would actually be able to deliver these essential services. So I think that if we've learned from COVID, so we've learned to think more about predictive models, where is our supply chain needed, learn more from data, etc. Hopefully we'll apply that learning pretty instantly to these other conditions. And I can't quite tell how quickly we're doing that. So I think that we were moderately well equipped to kind of fight this. And I think we still are. We have incredibly smart people working in public health across Africa. We have, innovative startups like Alara and mine that are ready to step up if we are given the chance through strategic partnerships. We have incredible support, internationally and locally pouring into relief efforts. It seems like to go from sort of moderately well-equipped to actually well-equipped, I'd like to see more strategic partnerships and kind of better coordination of everything pouring in. And of course, a focus on data that doesn't just look at the current issue, but sort of the things that intersect with it that could be missed along the way.
At the end of the debate, one of the things we want to talk about is collaboration and partnership. How do we bring out opportunity, technology, and data, predictive models? And each of us here in the room has a role to play, and see how can we have cross-sectoral collaborations among us in the room and also with some of our audience. And that will be, I'll spare that to the very last minute of the session. So going more to very specific questions, and our audience, please joining us online, feel free to drop your questions on the chat so that we can look at those as well. So this one is directed to you more, Dr. Teresa. I must argue that any pandemic like of this scale, any potential pandemic in future of this scale, needs to be stopped at its tracks. Yeah? I don't know where we dropped the ball when we knew as early as December about this disease, December 2019. The genome sequence was already published. And it looks like we sat and took our sweet time and just waited for the worst. So as an epidemiologist, and we hear as we are encroaching more, of the animal kingdom and encroaching more of our forests, and because of the demand of animal-based protein and food production, we are encroaching these natural resources that we shouldn't. We are crossing to another territory, and that's why these diseases are maybe jumping from zoonotic to human. And what do you think we need to do to prevent this, get ahead of this situation, if there is bound to be anything happening like this, be it Ebola, bird flu, whichever form of flu? How can we do it better this time?
Okay, I think that's a good question. I think just for the record, I think our Ministry of Health in Kenya has done a good job given the circumstances, because you're looking at a global epidemic that's unfolding. Nobody knows. We are all learning as we go. And the advantage some countries that were already dealing with Ebola had is that they already had the experience in dealing with the pandemic. So I found the response, the intersectoral response that the Ministry of Health took up was really commendable given the resources. And the way the epidemic was now moving from China, coming to Europe and to Kenya, we basically had to wait to get the first case. So it's really about doing things as we go. But from what we've learned now is that we can do a lot together, and it has to be a multi-sectoral approach. And we have a lot to learn from other countries. We learned a lot from what China had done and other countries that are ahead of us. And that also helped us to be able to preempt any kind of challenges that we would have. So even that partnership and collaboration, the cross-pollination of ideas and strategies, what has worked and what hasn't worked, really helped the task force to be able to do their best. So I think in future, the best thing would be, I have been part of a panel where we were looking at developing the universal health benefits package, and one of the goals was to institutionalize health technology assessment. And I feel this is really the way to go. The way COVID has actually shown us, we really need to institutionalize an emergency response in a way that should we get another epidemic, we basically know where to pick it up from, what to do, and what to do. And it's important at this point to do a cost-benefit analysis and really look at value for money for everything that we've done. Training, for example, a lot of training was done online, and that was quite efficient, but usually training has to be face-to-face for you to be sure that your trainees have been able to acquire what has been done. So a lot of training then has gone on has been done face-to-face. So I think just looking back and looking at the cost-benefit analysis, and bearing in mind that we will still continue to deal with the shortages just because we are not in the income country, we need to ask ourselves how best can we deal with what we have to be able to reduce mortality and morbidity. And of course, now with the reopening of schools and the reopening of our airspaces, we are still learning as we go. But I feel now we have a grip of what needs to be done, and come another epidemic, things will actually be done better. And also because the Ministry of Health really used a whole round approach where they involved all different sectors, and that also reduced all redundancies, and we were able to put in technical expertise to the response. So I think we've done well as a country, but of course we could have done better.
And I totally agree. Actually, this question was coming more from a global perspective. I agree. As a country, our frontline soldiers have done a commendable job.
Actually, we need to move our surveillance not just national to a global level and make it more like Africa-wide, if you're looking at Africa, and also be able to link up with what we have in other countries so that we have a real-time data source and from the health facilities in the region, and that will actually be able to help us know what is going on, because unless we have the evidence, then it's not possible for us to know what is going on. And this means that operations research becomes a key thing for all of us, and this can work very well because it's blended into the implementation programs. So if you're looking for funding, you basically just need to look for funding to do operations research nested within the implementation spheres, and look at common protocols. For example, what WHO did in terms of assessing contamination of surfaces, they came up with a common protocol. I wish that would have been done for most of the others. So if you're looking at surface contamination for COVID, then you have a common protocol that you can use. So if you're able to come together and look at common protocols for operations research, even get appropriate sample sizes, because sample sizes, of course, have been a challenge in terms of interpreting the validity of the data, then that would be good. So if we can do a global research plan, which we already have one in WHO, but one that is now customized to the needs of each country, especially looking at surveillance, that can actually help us pick up the early warning signs for most of these diseases. And of course, protect the people at risk of non-communicable diseases.
Thank you. And that leads to the next question. I think you pointed to, you've hit it home, that there's a role for data science in all of this.
Yes.
We need evidence. For example, we didn't know to what extent did, let's say, staying at home, locking down, help, yeah, compared to people who never locked down?
Yeah.
To what extent did hand washing help? To what extent did the thermal guns help? And now, switching over to you, Diana, is there a role for AI, machine learning, data science, first of all, in managing future pandemics, but also in running a corporate healthcare scheme like the one you're running at Bamburi?
Yeah, so the two-pronged questions. So in terms of pandemic, just building up on what Teresa has said, yes, there's a lot of opportunities for AI and machine learning, because one of the things that's happening is that different countries around the world, everyone is producing data. But this data is not being aggregated somewhere to be able to inform decisions that can be taken. So with that, there is actually an opportunity to be able to aggregate all this in terms of managing pandemic. Now coming to corporations for such as where I work at Bamburi and looking at using AI, machine learning to be able to support employees, especially when you look at these health plans or medical benefits that employers offer as part of employee value propositions when you think about it. So one of the things that has been happening for a very long time is that we've been having standardized medical plans. They are not innovative. They are not informed by anything. So I have a cover, let's say, I say inpatient, I'm giving you an inpatient limit of 5 million. What informs 5 million? It's not based on any particular information. So what informs, because we know that when it comes to pricing, we know that the outpatient benefit is priced more expensively because we say at least people have a frequency because it's available, they will be visiting healthcare services. But we do not consume that data to look at this age set. How many times do they frequent health services and what are they frequenting for? So that then if you are developing a medical plan, then the medical plan meets the need of these particular people. And I think with this situation for COVID, one of the things I see in the near future, which we have been asking for, is that very soon people will be having flexible contracts. So I may be working for Bamburi Cement as one organization and another organization at the same time. So as a result of having flexible contract, then also it means that when it comes to the benefits that I receive, they must also be liquid and flexible in nature. So that will be very important. And now we have a new generation Z that is coming into the healthcare space. So something like this, it doesn't resound to them. But if you tell a person in their 40s, 50s, they have a medical plan, it makes sense to them. So there is a lot of opportunities to disrupt the rigidity that we have in the insurance space and medical covers.
Thank you. As you're speaking, my mind kept going to Huduma number, which has now resurfaced again. And I'm like, how powerful would it be, to have that patient profile, personal health profile in my Huduma card that has my hereditary conditions, my NCDs, my history, my age, gender. And now whoever is creating a scheme or a cover is custom making it because we all have different in terms of healthcare. And hopefully if anyone from government is listening and we can send Dr. Teresa that we want this added to the Huduma number to really help us manage our healthcare. And now I'll switch over to you, Maximilian. I know earlier on you spoke about the barriers to access. But going again back to data and AI, I know you have some of the very innovative devices. How is this, first of all, two things, how is this helping address the patient-doctor ratio, the patient lab technician or the patient pathologist ratio, as the machines get wiser and smarter? Can that be used to address the HRH gap, the human resources for healthcare? And what are you seeing there?
Definitely, and I think if we look at your Western countries as the perfect examples as those environments where companies are disrupting the space, aggregating incredible amounts of data that we've never yet had, and coming up with smart algorithms to improve the workflow of these doctors that otherwise need some additional support to provide the quality of care they need. What we see is a massive opportunity to leverage those learnings and try and, one, building basic infrastructure here. How can we start generating data? How can we start collecting an understanding of the patient profiles? As Diana, you were mentioning, it's incredibly crucial to start mapping out personal health. And then two, how can you start building trained models to facilitate with diagnosis, to try and bridge that specialist gap that you see otherwise across the wider continent, and give tools that, quite frankly, don't yet exist here to the clinical officer, who then doesn't need to lose a patient because they will not be referred elsewhere. So we see a massive opportunity, although we still have to start at the basic. Build that data collecting infrastructure and understand what the patient profiles look like, and then leverage your analytics on top of that.
Thank you. And over to you, Melissa. I think you had already hinted to this. Hearing from these esteemed panelists, what opportunities for collaboration are emerging from where you sit as Access Afia? What cross-sectoral collaborations and partnerships do you see emerging, if any?
Yeah, what's the opportunity for, and what are we seeing actually happening? So I guess the first one is just to build on this theme of data and AI. We've received a lot more interest kind of globally to think about the predictive side. So you can use data to help respond and also to help predict. So we've had some exploratory conversations with people at MIT's Media Lab around how to have a more sensing city. So how do you kind of use, I mean, you walk around Nairobi and there's infrared thermometers everywhere. Imagine if this started to create kind of like a heat map, and maybe even was with us, past when we properly flattened our curve. It can help us think about the next thing. And then of course it's not just temperature. If you actually kind of had this interactive map, you'd want, pulse ox and other types of vitals to be on there as well. So I think that from a more sort of academic and smart city perspective, there's going to be a lot of interest in investment, and that's a way to bring together not just healthcare startups who are collecting data, but actually urban planners and public space innovators, private sector, the forest, our cafe, you're getting your temperature taken at all of these places. So I think that's been really interesting. Bigger picture partnerships. I'll also grab something from Nicola in the chat. I mean, one thing that we've been thinking about is health financing, which has already kind of been said, but I think that this was sort of collaborative way to think about health financing is essential. Because again, to kind of hit home the point previously made, if you're going to see a breakdown in essential health services due to a pandemic, it's partially because people are nervous to come to clinic. In our experience, it's mostly because people are broke and they've lost their work and they're staying home. And so it's harder to then access services. So I think that there's a big opportunity to create this safety net by working with innovative companies like Bamburi, microinsurance agencies, and super low cost healthcare providers like us and some of the ones Lara works with to kind of create better partnerships around the financing side. We spent a long time talking about health financing and running our own micro membership product, and really this year we have seen an acceleration of the number of financing partners who want to work with us. And I think it's partially by sort of this shakeup in the health system causing everyone to rethink things. I think that the other area we're really interested in is how to improve public-private sector collaboration, because ultimately the work that we do and the work a lot of people are doing fundamentally falls under an umbrella of public health. Whether we're educating, whether we're talking about hand washing, even if somebody's coming to us for a paid respiratory visit, they're asking us questions about COVID myths. We're doing a ton of patient-facing education, and we're doing a ton of services that, to be perfectly honest, even in a private sector clinic, will just never make money. So we immunize because it's the right thing to do, and so these are services that we maintain. That is something that I think can evolve into we can be a tool in organizations like ours to provide UHC in a more kind of creative, look where you have multiple pieces of the puzzle. It's not going to be all free public hospital services. It might not be 100% the answer to just roll out the existing NHF product. But I think that if we work together to bring financing that is more flexible and customized, like has already been said, providers that are being sort of forward-thinking, data-driven, and can be held accountable to impact metrics, not just submitting bills, but actually submitting results and outcomes. I think that this is definitely where we need to go. We've seen some early movement in this direction, and definitely hope to see a lot more.
Thank you. And I think we're going to open up now to the
maybe Maximilian, for you to jump in there. I know you've commissioned a study with some academic institutions for the butterfly. What other opportunities are you seeing? Maybe speak about that a little bit, and then also other opportunities that you see, for example, for working with academia to bring evidence-based medicine or evidence-based approaches to care.
Definitely, and I think in the latter, where academia can be an incredible push, it's validation of models like our own and like Melissa's, and it's with that empirical understanding that what we're trying to solve actually works, you then can access wider buy-in from the whole ecosystem, and that will just accelerate what we're trying to achieve. And somewhat pivoting to your previous question on cross-sectoral collaboration, to get that buy-in, that understanding of a need for a holistic intervention across the board, from access to diagnostics, to high quality meds, to bringing in educational components to teach not only patients, but equally providers, as we see a massive gap on that front, is to have some form of academic backing to get that buy-in, to bring people into the fold and to facilitate cross-sectoral interventions.
Thank you. Absolutely.
Yeah. So thinking about just jumping into the conversations about collaborations. So from like where we are operating, like a number of private organizations, what we've been able to see is that, in our own little way, we are able to do something here and there. I mean, I can cite like one of the collaborations we've had as an organization is partnership with Ministry of Health to start a maternal child health program within our facility. So where mothers come and receive healthcare through our staff, who we support the medical team. But most of these commodities and consumables we get from government. So, that enables that the program is sustainable, it's not expensive, and we're able to serve this community of mothers around us and contribute in our own small way into this. But that means that is us on our part. But when I look at it and look at also other organizations where people like myself are playing at, what I realize is that we have small pockets of excellence. So it's sort of like a fragmented efforts, so to speak. So if there is indeed a drive to and a push towards collaboration, and you say Bamburi is playing in this space, this other person is playing in this space, it allows everybody to play in different spaces and be able to get a bigger outcomes, better impacts when it comes to health, as opposed to I play my small thing here, you do your small thing there. So indeed, collaboration is the only way for us to have a sustainable and meaningful impact when it comes to supporting the communities around us.
And as you're speaking, my mind goes to technical working groups. I don't know, Dr. Teresa, if you are aware of any where we need someone to anchor this type of collaborations so that it's not fragmented all over the place. Yes. I don't know whether there's a TWG we can plug into, or do we need to initiate one which we can all feedback to?
Actually, I think with the Ministry of Health, there are a lot of technical working groups. I'm actually a member. For example, I'm a member of the Division of Geriatrics Technical Working Groups, and basically that brings up anyone wanting to work with older persons. I'm also a member of the Malaria Interagency. There's the health financing. Actually, it's all a question of information sharing, because with information sharing, then we know this TWG exists and this is what is required, because that really shapes up the needs of the industry and how that is faced in the industry. So I find this an opportunity for us now to be able to plug into the different relevant TWGs and even make a presentation of what you do so that the other members are aware. Because I think the working in silos that Diana talked about really has to do with just us not knowing, the lack of information sharing.
And coming from social enterprise sector, this is very true. I mean, if you're not a practitioner in healthcare,
yes,
these things are out of your radar. You're not
Yeah.
aware that there's even anything
Yeah.
like a TWG that exists.
Yeah.
And is there a place, a repository somewhere on the ministry's website where someone can, like Maximilian, can go and see, oh, there's a TWG on data science and health, or there's one on MNCH.
Yes, yes.
Is there a list, or is there a resource where we can go? Or we need to see you after the meeting?
No, I think now that you made the contact, I think it's really important that we help you plug into the relevant one that you'll be required to do.
And
Let me give you an example. I sit on this TWG for older persons, and the long-term idea is to get retirement homes for older people, just infrastructure. So why wouldn't somebody from the Architectural Association of Kenya be sitting in that group? And then you wonder, what does an architect have to do with it? But you see, you're looking at the social protection for the older persons. So it's all about what is it that you want to do, how you can plug in, and I'm sure you'll still be able to get in. So I think maybe after this we can discuss, then we can link you up with.
And for our audience, you can inbox me and I'll connect you. Yeah. So as we go to the home stretch of our session, I think this was just a precursor to a COSE conference, which will be happening towards the end of November, where we will dive deeper into some of these things that we've surfaced. And as we wrap up, I will also we'll go again around the room, starting with you, Diana. And the question is, why are convenings like this or a COSE important in developing a thriving ecosystem?
Oh, well, that's a very good question. And really, it's part of the reason why we're here today. Because as you see, we all have, there are pockets of excellence all around us. We are stars in our own ways, but coming together through this convenance, this kind of meetings helps us to learn what's happening out there. So this platform for me is more of a platform of knowledge sharing, so that we're able to know who can I partner with. If I'm interested to do more, for example, in the space of machine learning and AI, I can look for Michael and we can look and see what can we do maybe in our space where we do a lot of, we work with truck drivers, for example. And that's also another space that needs to evolve and into something else when you're looking at things around road traffic accident and things like that. There's a lot of opportunities. But I think the thing is when you look at yourselves, there's a lot that you're also doing, but you don't want to get bogged down into the creation, which such meetings provide an opportunity of someone who can actually take away the pain and the headache and be able to develop that for you. So for that would be my take, that spaces like these are really important for showcasing best practices. Information is pulled out there. You take it and you replicate it with pride wherever you are.
Thank you.
Yeah, I think I agree with every single word you said, and to add on top of that as well, it's also a space for challenging those ideas. It's a space for exchanging them, for having different optics, for agreeing, for completely disagreeing, and they act as their own, call it incubator of sorts, for new plans, new potential partnerships, new way of possibly doing business. So I always view these panels as incredibly interesting from that point. I'm listening to something you're saying from a very different world, which I may agree with or disagree with, and likewise on your end, and likewise on your end. And that exchange of ideas hopefully comes out with something better, something more innovative, something that will take us to the next level to achieve that goal of sustainable healthcare.
I think for me, Africa, this is a time for Africa to become a producer of health innovation as opposed to a consumer, because we have a lot of ideas. Look at the hand washing station that was created by a 9-year-old boy who got a Mzalendo award. That was just one case. We have, Diana says our average age is 20 years. We have a lot of young people with good ideas who basically we can be able to create and nurture to be able now to be self-employed and be producers and company owners. So let us look at Africa and our young people as a resource. We know what our problems are, and we know what the solutions are. But again, there's the best practice, there's a global best practice that needs to be applied. But looking at the solutions that we have for Africa, our solutions will actually come from us. All we need to do is to collaborate. And again, we know most of the donors will fund consortia, And usually if you have a Pan-African consortia, that's most likely to be funded than a national one. So I'm looking at us thinking beyond Kenya, looking across Africa, and just trying to see what's happening in Ghana and coming up with a Pan-African innovation. And that will actually be more sustainable.
Over to you, Melissa.
I don't have so much to add on this, but I had someone send a direct question, so maybe I'll give a couple of notes on that, if that's okay. Totally believe in the value of this collaboration and these types of discussions in widening our network and understanding the changing landscape. So echoing what everyone said and not too much else to add. I did have someone send me a direct message because actually part of the reason why we were part of this network was through a project we did with Making More Health, which brings together Ashoka, Boehringer Ingelheim, which is Ashoka is a global network of social entrepreneurs and people who support them, and one of the sponsors of this one. And then Boehringer Ingelheim is a German pharmaceutical company who is sort of rethinking their next 100 years and how they're going to get into Africa as a continent, and also what they're going to do, as their core business inevitably has to evolve as patents expire. And so what they designed is a project called Making More Health, which brings together a lot of the healthcare expertise and business acumen that Boehringer has as a company, but actually works with social entrepreneurs by co-creating specific kind of pilots and activities to do together. What was really interesting for us in this is you actually are working not necessarily through a foundation or a CSR program that's disconnected from the business, but actually with their R&D team. So these are people who are actively thinking about what are the future business models that are going to unlock value. How does African healthcare work? How does Kenyan healthcare work? How do we get better data out of the system so we can understand what to do next? And by actually having them put sort of their corporate teams with us, I think it kind of shifted the focus to getting to work on things where you're just kind of 100% aligned on the result is to create a sustainable and growing concept. And B, it was able to kind of work with a team that has kind of a long-term interest in building up the sector so that they can have better partners. So I just wanted to tell that as a story of another interesting way to structure a partnership. I think so often you have a company with a core business, an R&D team, maybe commissioning reports and hiring consultants and collecting data and hiring analysts, and then a CSR team who's kind of giving away the excess profit. And this was a really interesting way to knit all of that together. So yeah, I mean, this was a great example of a German pharma. Are there big Kenyan companies who would think about this approach? Are there East African companies who would kind of think about how do we shift some of our R&D budget to putting together pilots and innovative concepts with corporates and entrepreneurs sort of in this market. That's my thoughts, my last thoughts on innovative collaboration for today.
The corporates themselves becoming disruptive, and encouraging. How can we train thinkers right from primary healthcare? How do we nurture this right from the very early stage? Because most of us grew into it while we were already in the corporate world, and that's when we learned about innovation. So can it be integrated in our curriculum? And I think none better to answer this than you.
Oh my, the hammer just keeps falling on me.
Yes.
I think this is a perfect opportunity because now we've moved to, our education system is changing and it's more comprehensive based. So looking at it, then we are going to train our children to be more innovative. So being able to challenge our children right from primary level with ideas, the key issues, just like the way the example you gave with the boy, and not just wait for them to be consumers would actually be very good. So having practicums that are relevant to the world issues, the teacher being identified, now we have COVID, what can you do about COVID? How can you get, for example, someone who is to the facility in terms of mobility? What kind of cart can you make? Maybe one that doesn't consume. Just letting the children know what the problems are and being able to identify. And this is where we find that the academia need to talk to industry so that the industry can be able to say what they really need. Because if that happens, then it becomes more relevant to what we are producing. And also having school competitions, for example.
Exactly,
Yeah,
yes.
having prizes per county challenges.
Yes.
If you put in like $2 million for a county challenge for a specific thing, and Ilara, I think this is something that you can do through partnerships. You'd be amazed at the kind of things that children can actually come out with in school. Even if they're working from home, they'll still be able to come up with a good challenge. And that would actually, because what really discourages people is the lack of finance and the lack of opportunity. Yes, you have a good idea, you're sitting in Tharaka Nithi, but nobody will ever discover you. So is there a channel in which you can be able to discover these ideas and then be able to nurture them? So I think this is a challenge to you, Maximilian, to just think about a county challenge. Yeah, and that would really be a good thing. And it's something we can do as a consortia to be able to come up with a challenge.
I totally agree. How did you know I'm from the Rakanidi?
Oh, really? Sorry, I'm just saying that very
I know.
Yes.
I will make sure the governor starts
Yes.
a county innovation challenge.
Yes.
I think we are the top of the hour. You've heard from our esteemed panelists, and this is more the reason why you should register for the conference. You've had this opportunity for collaboration, there's opportunity for networking, there's even opportunity for scale, because this conference will be Pan-African. So if you're a Kenyan startup that needs to expand to Nigeria, this is a conference where you come and network. And as iron sharpens iron, I learn more from these panels and discussions. As you can see, I was scribbling a lot of notes as the panel was speaking. And this is how you elevate your thinking. It looks like we have one more question. I think we can take one more question from the audience. If you can zoom that a bit. So the first question comes from Frederick. Says healthcare innovation or any advancement in Kenya lacks credibility due to poor governance. Most of these solutions are poorly thought through. So long as our models of healthcare are poor, everything else hangs on the loose ends. And we agree with you, Frederick, and that's where the role of data comes in. You know, nothing speaks more truth than data. Data never lies. So we're talking about evidence-based approaches to see these solutions working, and we avoid the hype. I am anti-hype. I am against hyping things for the sake, because they are cool and fancy, but really are they working?
I think I just to also add into that, because when you look at the 6 pillars of what makes a good healthcare system, one of the pillars is leadership and governance. So if that pillar is not working, then for sure your healthcare system is broken.
And I think also when you think about stewardship, because for example, in terms of innovation, there's funding for innovation, but sometimes you find some donors get tired because people are not true to the concept.
Yes.
So you want, I give you $2 million to work on something, but you spend 500, the rest you go and buy a farm and build a big house. And yet we are looking at quality. How are you able to achieve a quality product? So I think again, integrity and remaining true to ourselves will actually be true, because if you really develop a quality product, then it will sell all over the world. So it's really about stewardship. Are you doing what you're supposed to do with what you're given? And that, of course, then will stimulate donors to produce more.
I agree, and that's where social entrepreneurship exists, where we're shifting the mindset from pure charity, where we're giving things away so that we can write a good report, to actually flipping out on the table and saying, we're going to sell it affordably and we'll ensure it's quality. And the market also never lies. I mean, people will only buy what adds and transforms their lives. So that's one other way of looking at it. The second question is from Patrick Lumumba, and is asking, how are the panelists change makers in their organizations? Who wants to take that one?
I think I can start with that one. About change. So one of the interesting things, as I said, the organization I'm representing here today, its core business is making innovative constructive materials. But one of the things that we've been able to do, and I think have been able to do, especially in my role, is to be able to show that even as we look at sustainable development in terms of construction, and which plays largely in the space of economy, you cannot, this other aspect of people cannot be left behind, because now the new tagline is smarter, greener, and healthier. It cannot be green if you've left health part of it. So in order for us, even as we play in that space, so I've been able to push for this within my organization. I thank my organization because it's usually open to ideas, and every time it's to look at what can we do differently. I think the guys who work with me in the space of medical insurance, they'll tell you that is the one radical corporate person we have right there, because I always say, why should something be like this? Why can't it be like this? What has informed your pricing? And let's challenge this so-called mathematical modeling. Is mathematics informed by the reality of what is happening today? So you don't put for me some formula. When you put the formula, is one assumption people, that sort of a thing. So yeah, I think, and with that, that's how we've come up with Afya Nguvu and many other things that we've done within our organization. So for that, I consider myself a change maker in my own small way.
Thank you. You've spoken about two things.
Yes.
Being entrepreneurial, that you don't have to go out of your organization and go start something out there. For organizations like Lafarge and others, you can innovate while you're inside.
Exactly.
And are you accepting nominations for Changemaker Awards or any? We can vote for you.
Thank you.
Top 40 under 40.
I guess, Lauren, it's hard for me or anyone in our company to identify as a change maker when the company in and of itself is trying to push some form of change. And I know it's somewhat of an evasion to the actual question, but if it boils down to what we're trying to do, right? Enable access to diagnostic, take those diagnostic results, feed them back to the patients, find ways to close the loop, bring patients back into facilities when otherwise they wouldn't be coming back. All of this is tantamount to change. And it drives from what I do at the company, which is coming up with a vision, which goes to our sales team that maps out the facilities we need to work with. So I'm sorry, Patrick, I can't say I identify as a change maker necessarily. We're surrounded as a company by every employee who is an own change maker in their own way.
How about you?
Yeah, for me, in the Public Health Society of Kenya, we are really preaching preventive, promotive, because health is just curative. Whenever you talk about health, you think of a doctor being sick. So can we think of health benefits, how I can live a healthier life, more of health expectancy versus life expectancy, more of a better quality of life. So we are really looking at trying to work with governments to invest more in preventive and promotive services, to actually look at health promotion under the universal health care other than curative, because we are really heavy on curative, we are heavy on commodity management. Everybody wants an injection, they want some medicine when they go to the facility, but they wouldn't want an exercise prescription, for example, or a healthy diet prescription to stop smoking, that kind of thing. So we are looking at more of prevention in the community, preventive promotive activities, being our champion. As you can see, we are looking at a safer and healthier country. And to me, that is my passion. So anytime you pitch something in health, where is a preventive promotive component? How can we be able to do that? Because you're able to use more and to save more with that. From the academia, I always challenge our students. How is this going to make a difference? So they come up with a project and ask them, how is it going to make a difference? How will it also help you as a student advance your career and help the community? Even looking at entrepreneurship. So we've moved away in the medical school from just doing projects that would just be good to know and nice to know. It must address industry and it must make a difference to the community. Otherwise, it's not worthwhile. And again, it can take that student to a higher level and get them to the international arena. That will actually be our joy. So I always challenge our students to think out of the box and think long term.
Great. Yeah. How about you, Melissa? Do you identify yourself as a change maker?
So I think especially as a founder, you're where you are because you had an idea and somehow got the courage to get other people to believe in it and back it. So I do. I guess sort of 8 years into my company, then the challenge for me is now, how do we get the kind of next generation of change makers ready? And I think it is sort of like on one hand, I totally agree that, well, you're part of a change, you're part of a company, so everybody naturally is. But then also we're kind of brainstorming, what else could we do to kind of embed that into the culture for the next decade to come? And so we've done some, smaller programs, like having, Hero of the Month recognition programs, by having some decentralized budgets where people can, test things that are strategy and vision aligned. And it doesn't have to go through kind of a normal approval process or be in the annual budget. But I do think that it's sort of an important area. I think that larger companies, I think, have this sort of stability and budget to be able to give people, sabbaticals and, to do sort of larger entrepreneurship projects. And I think as a medium-sized company, you want to bake that into your DNA, but find kind of nimble ways to do it. So we'd also love to keep talking to Ashoka. Definitely one thing that Ashoka's done for us is opened up an online entrepreneurship class, which is just all about how to start change within a company, instead of always thinking that to be a change maker, I need to leave and do my own thing. And I've had a couple of my team members take that, and they really loved that. So hopefully they will open that up to others.
Thank you. And there's no shortage of change makers around here. So whenever you're recognizing the next round of change makers, you can pick from our esteemed panelists. Now we are about to wind up, and as we wind up, one question to the panelists is, one, are you attending the ACOSE conference? And can you also encourage our viewers to do the same? Do you plan on attending the ACOSE?
Oh yes. I mean, when I think about the massiveness in terms of ideas and people to meet, and also just the opportunity to network with people doing great things, there are pockets of excellence in this sort of space. I don't think it's not wise at all to miss this conference. So I'd like to just tell anyone who's watching us, who's seeing us from wherever they are, please come, bring your ideas, come learn. It's a great networking space for all of us. Karibuni.
Thank you.
And as we were saying earlier when we were having the tea, that this is the start of a conversation that, quite frankly, has no end. So I'm definitely going to be going to the conference and take everything we've chatted about this week, today, and continue it forward. Absolutely. So everybody, more than welcome to join. Karibuni.
For me, I'd like to welcome all academia, because this is an opportunity for us to meet with other stakeholders and be able to brainstorm and see how we can work together. I'd also like to invite all the members of the Public Health Society of Kenya and all the public health specialists to be able to join, because this is an opportunity for us to network and come up. And anyone who has a health innovation, this is the place to be. So I'll definitely be there.
Looking forward to having you both. Melissa, will you be joining us for the conference?
So I guess, to be perfectly honest, I had not initially planned on it, but today was really interesting and engaging, so I will certainly reconsider.
In this side of the room. All right, you're encouraged, our viewers, to follow ACOSE on Facebook, on Twitter, to stay up to date with the events. There'll be a series of similar talks across different sectors. There'll be one on agri, one on renewable energy, as we build up towards the conference. So check out our social media handles, and we look to having you for at the conference. I'd like to take this opportunity first to thank Tangaza, our host, for this amazing setup. We never knew how this would work with half the panel in a physical location, but this has been fantastic. It's been a while since I saw some of my esteemed panelists here. It's been over 7 months, so I'm very grateful for this opportunity. And thank you to our viewers online. Thank you for your participation. We look forward to having you. Without much ado, I would like to thank you all Thank you, Ashoka, our partners, and everyone else who has been involved. See you at the conference.
Thank you.
Thank you.
Bye.